Good morning, everybody, and welcome here to this most timely event called Protecting Nursing Home Residents' Rights and Family Life Lessons for Ireland. I think it's an event that has touched a nerve, and it is channeling real life concerns of people living in nursing homes, in residential settings, their families, the people who care for them, and I suppose concerned citizenry. And that's reflected in the great response that we have here today, and the numbers of people who've joined us this morning already and have registered for the event. We have practitioners, we have politicians, we have policymakers, we have researchers, and indeed we have people like myself, concerned citizens. My own background is in social work, but I also was CEO of care organisations in disability and dementia, and I also did work as a senator on adult safeguarding and dementia. So a lot of kind of hats that I think many of us would be wearing. I want to thank the organisers and for the foresight of the Irish Association of Social Work, working with Dr. Sarah Donnelly in UCD for surfacing this important issue, for getting it the attention that it deserves, but also looking at how we can move forward from where we are today. We have 6 excellent speakers to hear from, so we're going to be strict on time. At least that's my job. And the speakers you'll see are Majella Beattie from Care Champions, Dr. Maeve O'Rourke from NUIG and a human rights lawyer, Ramona Backhouse, Dr. Ramona Backhouse, joining us from Maastricht via Germany this morning, Dr. Sarah Donnelly, Dr. Greg Swanwick, and Sinead McGarry from the Irish Association of Social Work. The event is being recorded because there was many people who wanted to join us this morning, but because of work that they were involved with, doing real life social work and other kinds of work, weren't able to join us this morning, and will be available on the UCD School of Social Policy YouTube channel, and indeed on the Irish Association of Social Work website. If you're minded to tweet, please do. The hashtag is #ResidentsHaveRights and #visits are vital. And for each talk, we will use a presenter view and only speaker view, and mic will be on. There will be a chance to ask some questions at the end. All the questions will be noted, and some we will have a chance to ask the speakers to respond to live. Now, one of the most important voices that the organisers really wanted to hear from this morning were the residents, the people living today in a nursing home or residential setting. And that actually proved to be one of the hardest things that we in the organisation of the seminar, is to be able to provide a platform for people themselves living in nursing homes to talk about their stories. And that's something I think we'll come back to. And I think it also probably tells its own stories in terms of the kinds of lives that people are living, and indeed addresses the matter at hand today about the conditions and the life and the family life, and indeed the human rights of people living in nursing homes, and their ability to talk, to tell their story, and also to express what it is they need and what it is indeed that they have a right to. But we do have a statement from a resident who's 91, and my colleague here, Cliona Murphy from the Irish Association for Social Work, is going to ground us today by reading out his statement to us as we reflect and debate and consider this important issue. So over to you, Cliona.
Patrick Coleman is happy to give his name to this statement. Patrick is 91 years young. He was asked about his experience of loss of family life, and he told us, "It was hell. I love my family. It felt like the family was disintegrating. I felt very small and insignificant against all opposition. I would have lost my mind if my daughter had not kept window visiting me. I don't know what I would have done without her. I don't sleep well, and thoughts keep going round and round in my head, stopping me sleeping, worrying about everything. What message would you give the government about their visiting policy? Patrick was asked. It was lousy. I watched a man singing and dancing outside his window for his mother, and it wasn't getting through to her at all. The new policy of 2 visits a week is a start. For that now that we are vaccinated, I would like to be able to get out, go home for a while, feel I have a life. What was your experience of life in a nursing home during COVID and lockdown? It was frightening. I'm a courageous man, but all I could feel was insecurity, powerlessness, that I was not getting anywhere. And Patrick's message for the government: get your boots on, sort out this chronic situation in nursing homes. The staff are excellent, but the government were a washout, too strict altogether. They need to get people vaccinated and end this nightmare so we can open up more.
We'll just give ourselves a few seconds, really, or minutes to absorb some of those strong messages. The word hell stood out, the word feeling small and insignificant, and yet this man describing himself as a courageous man, and yet who felt a huge sense of powerlessness. And his exhortation to government, and indeed to us today, is to get our boots on and to get on with addressing this really important issue of people living in residential care, in nursing homes, having access to a life, a family life, and a decent life, to be able to have visitors to come to as a start, but also to be able to get out. So now I'm going to call on Magella Beattie from Care Champions, who's done so much, again, to shine a light on this particular real life trauma, I would say, happening in real time. And Magella represents Care Champions, which is a family-run advocacy group, and set up in order to be, your own voice and to give voice to your family members living in nursing homes. You're also advocating for the statutory right to home care, which is something many of us would share, and to have a choice to live at home if people wish to do so. You set up 2 years ago, and you experienced the harsh reality of not being supported as a family, as carers, for the need of care, and having to make very limited choices for your loved ones. Our campaign is to challenge the narrative that our loved ones in nursing homes and those being in forced isolation, that is in any way acceptable, and essentially people being stripped of their human rights, especially to family life. So I'm handing over to you, Magella. You've got 15 minutes for your presentation, and we're looking forward to hearing from you. So over to you, Magella, and thank you for being with us this morning and for sharing.
Thank you, Colette. Good morning, everybody. I would like to thank Sarah for inviting Care Champions to participate in this valuable webinar. I will be covering 4 areas: an introduction to Care Champions, the experience of nursing home residents and families during COVID, issues with government guidelines, and before closing with a number of asks of our government. Care Champions is a family-run advocacy group formed 2 years ago to enable family members, often carers, and their loved ones to be heard. Nursing home staff mostly do fantastic work, often understaffed and for very low pay. Our group supports those who have had negative experiences with nursing homes. Over the past year, we have sought legal advice for people. We've assisted people to use government guidance to communicate and obtain compassionate visits in nursing homes. Many of those we supported, having tried all other avenues to no avail. We have supported over 350 families in crisis over recent months. We strongly believe that government could and should have done more to support safe and managed visiting, similar to other countries. All the experience shared today come with the consent from the families. Let us consider the experience of nursing home residents and families during COVID. Many who live in nursing homes do so not by choice, but due to the lack of statutory home care services and poor community supports, leaving them no alternative but the option of a nursing home. While for others, living in a community with care support and daily activities is an ideal solution. Everybody living in a nursing home, regardless of medical, physical, or cognitive challenges, has dreams, hopes, aspirations for the remaining months and years of their lives. Families are partners in care, providing love, assistance with nutrition, personal care, and routine. Residents confide their concerns regarding staff, residents, or abuse to their family during visits. Families are key advocates to address concerns. Families quickly began to notice a decline with their loved ones regressing. During outbreaks, staff shortages led to residents often receiving even less human contact. Families noticed relatives clearly distressed, depressed, sad, and cognitively declining. Nursing staff reported that many residents have mentally deteriorated. Some even stopped eating and gave up on life, resulting in death. Other families have witnessed weight loss and intense, cruel loneliness in their loved ones. Residents were regularly isolated within nursing homes, confined to their rooms for days. The lack of social stimulation was detrimental to many residents, as Ireland failed to copy better practices of other countries. Poor communication from many nursing homes prevented families from obtaining basic information. Families are often excluded from routine updates around medication and health changes. Often, when crisis support was most needed, phones went unanswered. While understandable in the first wave, why is this still happening a year on? Most families were only allowed end-of-life visits when the resident was unconscious. Residents died without messages of comfort from their family after a prolonged separation. Families are haunted by their experience. One home that did not allow end-of-life visits refused a request to hold the phone to their mother's ear, saying she cannot hold it and we don't have time. In one home of over 20 deaths in a 2-week period, some families were not informed for 6 or 7 days that their resident had tested positive. Others were only told after their loved one had passed away. Everyone has a right to family life. We regard the prolonged absences of regular visits as a refusal to allow residents their human right to their family. Their dignity has not been respected, nor appears to be valued by either the nursing home, the government, or society. Many nursing homes did not provide visitor pods, resulting in people freezing outside windows or waving up to upper floors. Despite updated guidance, some homes insist on screens when visiting, in excess of public health advice. Window visits are unsuitable for those with hearing, communication difficulties, or dementia, often resulting in residents becoming overly distressed. Visitation refusal is common. Homes regularly ignore guidance and refuse to put their visiting guidance in writing. Care champions are inundated regarding the right of the resident to have privacy in their visit with their family member. Numerous families report staff present during their meetings. Some visits were not held in separate rooms, but in hallways, beside a reception desk, or in a busy thoroughfare where it was distracting for all, but most particularly for an Alzheimer's or dementia resident who found it hard to focus on the visit. In some homes, multiple residents were given visits in a shared space, meaning privacy was absolutely impossible. We fully support the HPSC guidance. However, these guidelines were poorly adhered to across the country, with each home choosing their own visiting arrangements, particularly in the private homes. Some never permitted window visits. Others only recently facilitated FaceTime calls, although the government had provided funding. Unfortunately, digital and phone contact is unsuitable for many residents. Families who challenged the guidelines often found that staff and management did not know the guidance. Great difficulty was had obtaining compassionate visits. Recent new guidance is further ignored, with some homes working to their own interpretations. Some of the trends which families have noted during COVID outbreaks are families believing they were given false information in an attempt to hide the fact that COVID was in the home. Denial that people were unwell using generic responses. Calls and emails going unanswered. Commitments of regular updates not met. Many families have raised serious concerns around the standard of care their loved one is still receiving. For example, pressure sores, weight loss and dehydration, increased use of chemical control, poor dental and personal hygiene, e.g. toenails curved over toes, lack of fresh air for months, prescription of palliative medication without being seen by a doctor. Families of a loved one with over 20 deaths in a 2-week period believe that their loved ones were neglected on a large scale. There is a question mark over many residents not being afforded the opportunity of going to hospital. There is testimony of hospitals refusing to take residents and of hospitals returning residents with COVID, thereby infecting homes. Families and residents are very confused about how to report abuse. Care champions have a good working relationship with the HSE, social workers, and HIQA to directly report concerns in the public sector. Private nursing homes, over which the state lacks governance, are more challenging. Families highlighting concerns were usually not seen in a positive light. Many threatened with being told if they wish to keep window visiting or to take a relative home for a few hours when the restrictions lessened for Christmas, they must not speak to the media or post on social media. In some cases, residents were moved to other rooms out of the reach of families who protested. Many families voicing concerns were told by management, if you aren't happy, you can take him or her home. Families had to rely on voluntary efforts and advocacy services as government provided no advice on residents' rights to challenge visiting refusal. When care champions provided resources on rights and avenues, nursing homes suddenly facilitated visits, showing that guidance could be adhered to safely. Such emotional abuse of relatives, along with separation from their loved ones, will undoubtedly contribute to an iceberg of stress-related illness. Many nursing home residents and their families nationwide were treated appallingly in their final days, with many residents facing death alone and often frightened. A year on, it is worrying that we are still hearing the same stories. Many families were not offered end-of-life visitations, with many others denied access. Some were only told the truth when the person was at the point of death. Often, families did not recognize their loved ones as they had lost so much weight. Some families were told in confidence that their family member's condition was worse than what was being shared. In other homes, People had to watch a loved one die from a window. In many cases, families were told not to ring the home as they were busy. Despite the critical time in the life of the resident, there was no information given on a regular basis. As a final insult, many families did not receive all their loved ones' property, with some important items thrown out. It is hugely important that there is enforcement of the present revised guidance. In addition, government need to look at implementing legislation instead of guidance. We need proper regulation, safeguarding, and a point of communication for family. Without a clear pathway, a huge gap between guidance and practice evolves. Residents must have a say in their own lives, though for many, recent experiences prove punitive and prison-like. There must be accountability from homes for any substandard care provided. Care champions believe change will only come through sanctions on non-compliant homes and call on government to implement this. Government shortcomings include relying solely on restrictive visiting guidance with no alternatives considered, i.e. safe managed visiting. Investment in visiting spaces and pods was only offered after December the 20th after lobbying. There are still no penalties for nursing homes who do not comply with visiting or install visiting spaces. In summary, we have a number of key asks of government. Family must be central to all decisions relating to their loved one. There must be a legal responsibility on all staff to report neglect and abuse while safeguarding their employment. Indoor family visitation must be at the forefront of all care going forward. Visiting is residents' best protection. It was on its withdrawal that this catalogue of serious concerns occurred. The happiness, belonging, and security found particularly with family must never be withdrawn. In late life, and particularly when cognitively impaired, touch is often the most worthwhile or effective communication. Protected touch is allowed in other settings, even with a person who is COVID positive and must be returned to nursing homes immediately. Residential care must cease to comprise only of medical care and must support mental and emotional well-being. Family liaison must be provided during outbreaks to provide communication and connection. Continued investment in connection, safe and high quality private visiting spaces. Enforcement of the guidelines, including penalties for non-compliant nursing homes, and implement legislation instead of guidance. Thank you.
Thank you, Majella, for such a cogent and disturbing presentation. People describing situations of people literally losing the will to live or the ability to live, and certainly not the ability to live well, and families being haunted by what they experienced on behalf of the people they love, haunted by their lack of ability to be in touch and connected, and touch and connectedness stand out, and the weakness of the guidance and how it can be ignored and has been ignored, and how you document that, and the denials and the unanswered calls and the abuse, really. I mean, there's no other word for it, for people at their, frailest often and most vulnerable. And the centrality of visits. Visit isn't just a sort of an optional extra or a nice to have. It's fundamental to family life, to living well, to dignity, to humanity, and it is fundamental to human rights, which now brings us on to Dr. Maeve O'Rourke, and I'm delighted to welcome you here this morning. And I know, Maeve, you have to go as well, and we're delighted to have you. You're a lecturer in human rights in the Irish Centre for Human Rights in the School of Law in NUI Galway. And we're lucky to have you in our world, because you've been shining a light in many dark places. And today it's about nursing homes. And that is something that you focused on in your PhD, the potential for older people's experiences of mistreatment to be more effectively addressed by the rule against torture. And I think that's, you know, an important thing for us to actually think about when you think of the context that Majella most eloquently and most disturbingly described, and other cruel, inhuman and degrading treatment or punishment in human rights law. Maeve is a barrister, and we're delighted to have her here this morning. And you have 15 minutes, and we're hopefully we'll be able to take some questions to Majella and Maeve. So over to you.
Thanks so much, Colette, and thank you so much, Majella, for that extremely important beginning, and thank you to the organisers and to everybody who has been working so hard. I'm very conscious that of everybody who's presenting here, I've been doing the least advocacy, and there are so many who have been just relentlessly documenting and advocating and doing everything they can at the same time as also struggling through with their families and themselves through the pandemic. So thank you for that, and thank you for having me. In May of last year, I made a joint submission to the Oireachtas Special Committee on COVID, along with Colette, with Professor Kieran Walsh, Professor Des O'Neill, Professor Eleanor Flynn, and Associate Professor Sarah Donnelly, proposing a human rights-based framework for any examination of the state's response to COVID as it concerns nursing homes and other congregated care settings. And I know that many family groups, such as Care Champions and many other advocacy groups and individuals, are also calling rightly for human rights to be the framework for both examination and action in relation to COVID and nursing homes, and the Irish Human Rights and Equality Commission has done the same. And my aim today is to join you all in continuing to propose that orientation, that all discussion and action on nursing homes and the pandemic would be oriented towards human rights and constitutional rights, which I'll discuss collectively as human rights. So the first question is, why is a human rights and constitutional rights framework of analysis necessary? The first point I think is that's important to make is that a human rights framework is primarily concerned with the state structures that allow harm to happen and the structures that are required to remedy harm and prevent it in the future. So human rights laws and the Constitution apply to the state. Now, the caveat is, of course, and it's important for private nursing homes to realise this, that constitutional rights violations can be claimed in the Irish courts against private individuals. But I'm going to focus on the state, and apart from the Constitution, the European Convention on Human Rights and generally human rights frameworks only apply to the state. However, it's not just about what the state does directly to people. The state's human rights obligations under law include its obligations to regulate the behaviour and ensure protection of rights where people are in non-state or so-called private settings. So therefore, I would argue a human rights framework is absolutely capable and sufficient and appropriate to incorporate all of the concerns that have been identified already in a range of examinations, including the Oireachtas Special Committee, the Nursing Homes Expert Panel, Oireachtas debates, and everywhere else. And I think it's also important to note that because of the focus on the state and state structures in human rights law, it is not necessary to find and expose individual intentional wrongdoing in order for a human rights law analysis to apply. And it's really noticeable, of course, that everybody who has spoken, for example, to the Nursing Homes Expert Panel, you can see in their report, you can see Care Champions Day, everybody is recognising how hard individuals are working and that the vast majority of individuals are only doing their best. But that's why a human rights analysis is so crucial, that in times where we are loath, rightly, to criticise individuals, it is absolutely essential that we find the means to nonetheless, because of the dignity of people who are experiencing harm, to nonetheless be capable of saying, this was wrong on the basis of a human rights law analysis where things are wrong. This should not have happened. This violated your rights. these are the structures that did it, and therefore these are the structures that the state will change and that it's legally obliged to change. And so the point 2 there I have is the paramountcy of a person's human experience of harm. That's central to human rights analysis. It is a matter of human dignity that the state and all of us would apply a human rights law framework. Because again, it's about the person mattering as an equal person of moral worth in our society. So it's not about, well, we could have done better. Where human rights violations have happened, it's about being able to state that, and also about being able to protect the human dignity of people who need protection from future harm. And central to the human experience and the dignity that underpins our human rights laws is, of course, that the people themselves are the absolute experts, the ultimate experts in what human rights have been violated and what structures have led to that and required to be changed. And they need to be at the centre of how we are understanding what is happening and how we design our remedies and protections in the future. And certainly I think we're going to hear a lot more today about how that's just not the case. And the third point about why we need to apply a human rights framework is that it's the law. And I would hope that recognizing that would inject some urgency, but also would go to what care champions are pointing out and so many others, that many of the changes that need to be made are actually legal changes, and that the protection of law is required, not just changes in policy. I'll come to a few specific rights, but first I just want to note an issue that was highlighted by Trinity researchers who researched for an Irish Human Rights and Equality Commission publication issued in February of this year, who noted the public sector duty under the Irish Human Rights and Equality Commission Act, which is to say that all public bodies must legally have regard to the need to eliminate discrimination and protect human rights in the provision of services. And the Trinity and IREC report noted that NEFIT lacks the expertise to grapple with human rights and equality standards, and that once NEFIT's recommendations have been made, that there's little willingness at government level to apply human rights analysis. The researchers in the IREC recommended the establishment of a joint Oireachtas committee on equality, human rights and diversity, and the equivalent type of parliamentary committee in Westminster has done very important work in relation to nursing homes, human rights and the need for actual legislation to ensure visiting rights are indeed protected. And so I would absolutely concur that there is a need for an Oireachtas Special Human Rights Committee, and that one protected strand of its work should be the legislation that is required immediately in relation to nursing homes. And I'll move on then to a couple of specific rights under the Constitution and the European Convention on Human Rights. So before I move to visiting, I wanted to briefly raise, because of course it's absolutely crucial, the right to life. It's part of the Constitution, but it's been extensively interpreted by the European Court of Human Rights. It's been raised already in the COVID and nursing home context by IREC, the EU Fundamental Rights Agency, the English and Scottish Human Rights Commissions. It's non-derogable. It cannot be disapplied in times of emergency, and I think it needs to be considered alongside Article 11 of the Convention on the Rights of Persons with Disabilities, which explicitly states that all necessary measures must be taken to protect the safety of persons with disabilities in situations of risk, including humanitarian emergencies. It imposes positive obligations on the state, not just that the state has to refrain from unlawfully taking life, but actually, of course, that it has to take appropriate legislative and operational steps to safeguard life, including through properly regulating the healthcare sector. It also, the state, has to ensure effective investigations into death, and in particular where deaths have occurred in state custody or where structural failings of regulation appear possibly to have contributed to death. And this leads me to contend, along with, of course, a number of the representative organisations who have already called for this, that there is a need for a public inquiry. I think it needs to include but go beyond the issue of death, because as I'll go on to talk about, we need to consider the rule against torture and inhuman or degrading treatment. And there are specific obligations under the European Convention in terms of how such an inquiry should be run. And I would argue that there is a role for an Oireachtas committee to hold an open consultation, but prioritising hearing from people directly affected about how such a public inquiry should be established. Article 8 of the European Convention on Human Rights, also reflected in the unenumerated rights provisions of the Irish Constitution, is absolutely key to the issue of visiting, because, as Care Champions have pointed out, it protects the right to respect for private and family life, which is absolutely engaged in relation to communication and visiting with family members. And of course, it's a right that applies not just to the person in the nursing home, but to their family members as well. It's not an absolute right in the sense that the state is entitled under human rights law to interfere, but only if its interference is in accordance with the law and necessary and proportionate. And I'll talk about what that means briefly in a moment. And it's not just that the state has to be careful about its own interferences, but also the state has a positive obligation to secure respect for that right by private actors through appropriate regulation. And I've just made a point there that when the consideration is being made of whether the state has done everything it was required to do by way of positive obligations or whether it acted proportionately, the vulnerability of a person, including their situational vulnerability or their inherent vulnerability through illness, for example, is absolutely relevant to whether the state has done all that it should have done. And so factors that I think we need to consider in our particular context are, number one, and this all influences whether the state has done everything it was required to, the nature of the interference. And so we really need to hear from people what they have been experiencing. Then the proportionality of the measures must consider, the extent of consideration about what was going to be applied, how it compares to what's reasonably achievable elsewhere, for example, in other countries, what safeguards and mitigating measures have been put in place, and whether in any case there have been blanket restrictions, which it's quite clear are unlawful. And I think a really important question that has to be asked in our context actually is whether the area of visitation, both in state-run nursing homes and through the state's regulation, if any, of non-state nursing homes, has actually been in accordance with law, because that's the first requirement under Article 8 ECHR. And the meaning of that is that the law under which the restriction has been carried out has to actually be clear, accessible, and sufficiently clear that people can regulate their behaviour according to it, and that the discretion of those who are in authority is clearly demarcated. And I'm actually not sure that the HSC guidelines have the quality of law that Article 8 ECHR requires. Moving really briefly, I won't dwell, but Article 14 of the ECHR's right to non-discrimination, it has to be claimed in addition to another substantive right, so goes alongside Article 8. It's also a standalone right in the Constitution, and we have equality legislation. And similarly, proportionality considerations are key, and questions around, well, actually, what could have been done differently? What could be done differently? How have other countries done it? Why have we considered those things? And how are we mitigating impacts are all very important, as well as the quality of the law. And then the final right that I want to focus on is Article 3 of the European Convention on Human Rights. It's an extremely important right to consider, particularly in relation to end of life. It's got a huge connection with the concept of human dignity, and it's an absolute right in the sense that once a form of treatment or experience of a person is acknowledged to fall within the category of at least degrading treatment, then there is absolutely no defence for the state failing to protect from that kind of treatment. The state can't argue we didn't have the resources. Prison conditions cases would be a prime example of this. If a prisoner is denied basic needs, fresh air, access to sanitary conditions, the state cannot argue we didn't have the money to do it, because dignity is so important, and because, of course, there is a method to determining when degrading treatment has actually happened. It's important to point out degrading treatment does not require malintent. It can arise through structural resource deficiencies. Dignity is central to understanding if degrading treatment has happened. And so I understand dignity interferences under European case law to arise where there is an interference with a core aspect of the personality, where the person is powerless to avoid that. So sense of self, communication with others. And also we see in the case law where feelings of humiliation and debasement and worthlessness have arisen. And again, this could be for family members as well as people in nursing homes. It can be objectively identified, so it doesn't have to be that the person is able to say from their subjective experience this happened. And that's important, where we can see objectively that people's dignity is being undermined and that they're experiencing those dignity violations. Again, okay, and then so these will be available, but I think it's just important to make that point about the Article 3. And then because all of the slides will be available, there's no need to go through this, save to say that everything that Care Champions has recommended, I would argue, is required under human rights law. And so you'll see here that a list of recommendations that have been made. I actually think many of them need the force of law. So thanks, Colette, for keeping me on the straight and narrow.
Thank you so much, Maeve. There's so much in there. Basically, what you're saying is we have the law, we've possibly been breaking the law, and we need to use the law. We might need a committee, we might need a public inquiry, and we have a clear list of what we want changed, and for the state to take up its positive obligations. Dignity is one end of the spectrum, and that's what we want for ourselves, and degrading treatment is the other end of the spectrum, and there's no debate about that. So thank you, and apologies for having to.
No, thank you for that.
So now we're going to get a chance to kind of move from Ireland and to move to a kind of an external perspective, and we'd like to welcome Dr. Ramona Backhaus, who's joining us here this morning from Germany, but works in Maastricht University, a senior researcher, and contributes to a Dutch National Monitor study on visitation in nursing homes during COVID-19. So very, very, very live research and evidence relevant to the conversation that we're having here this morning. She is conducting research in the field of staffing and quality and care of care in nursing homes within the Living Lab of Aging and Long-Term Care. Her colleague, Dr. Hilde Verbeek, was meant to join, but life took over this morning. So we have Dr. Ramona. So hand it over to you, and you have 15 minutes. Thank you, Dr. Ramona.
Thank you very much. Good morning, welcome everybody. We are very glad to being invited here to give a presentation on our findings. Also on behalf of my colleague Hilde Verbeek, who isn't able to join today, I would like to really thank you for giving us the opportunity. I'm going to talk about a study that we conducted for the Dutch Ministry of Health about visitors in nursing homes. And when the ban on visitors ended, we were invited by the Dutch Ministry of Health to monitor what was going on in nursing homes. So actually, we now have a sample of 76 nursing homes that we are following for about a year now. And I'm very happy to talk about that today. And I didn't do this alone. So I had some colleagues from Maastricht University, but also others from Nijmegen University in the Netherlands who joined in that study. Let me just start with saying something about the Dutch setting. So at the moment, there are about 17 million people living in the Netherlands, and out of these, 115,000 people currently live in a Dutch nursing home. And when it comes to COVID-19 infections, I present here a figure where you can see how many infections took place. So in this figure, you see the number of residents that suffered from COVID per day. And you really see that it all started in February and March of 2020. The summer months, there were not that much infections, and then back in September, October, we saw a second wave starting. And in January, we started with vaccinations in nursing homes, and now we see that the number of infections is decreased. If we have a look at the deaths, as of March 3, about 4,000 people or 4,000 residents of Dutch nursing homes have died due to COVID-19. And I think the presentation from Magella made very clear under which circumstances people died, and the things she talked about were also happening in the Netherlands. So it was a really horrible situation. When we have a look at the Netherlands, there was a national ban on visitors on March 20 in 2020, when there was a big lockdown. And in the southern part of the Netherlands, where I'm working, already 10 days earlier, organizations had to close because we had some bigger outbreaks in the south of the Netherlands. This ban on visitors was a highly restrictive measure, Magella indicated already, and in the Netherlands it meant that no family was allowed to enter, no friends were allowed to enter, and also no volunteers were allowed to enter nursing homes any longer. That was problematic because we see that normally a lot of volunteers are helping out in nursing homes and are involved in daily activities for residents. And what we also saw back then is that only health services were only allowed to enter if it was really necessary. So all medical treatments did not take place any longer. We were happy to see that nursing homes started to come up with what we call creative alternatives. So window visiting was allowed, separate containers were put outside where people could see each other, and also telephone calls or iPad calls were used. Nevertheless, it was a very serious challenge to residents' autonomy, and we already heard that people suffered a lot from that. In the beginning of the ban, no researchers were allowed to enter the nursing homes, so all the evidence that we had was really anecdotal and primary data were lacking. Then in May, the Dutch ministry decided to cautiously opening doors of nursing homes. It was 2 months after this visiting ban, so about 2 months nobody was able to enter the nursing homes, and residents were not allowed to leave the home. We were, as I said, invited to conduct a pilot study on behalf of the Dutch Ministry of Health, and in the beginning, we included 26 nursing homes, and they were allowed to open doors for visitors at May 11. And in June, other nursing homes followed, of which we included 50 additional homes to have a bigger sample to monitor. They were allowed to open doors under very strict conditions. So there was a specific guideline developed with strict rules of what a visit should look like. And these guidelines were developed by stakeholders in the field, for example, professional organizations, old age medicine, psychologists, nurses, but also client representatives were involved, the Alzheimer's Society, and the sector organization, that's the branch organization of nursing homes. And some key points was that each resident was allowed to have one designated visitor. They could visit only once a week and only on a planned visit. It could last a max of 1 hour. They indicated that the visit should be supervised. That meant that a staff member was there to have a look at whether they follow up all the restrictive measures. And there was some room for the local context of a nursing home. So, for example, some homes decided to have visitors in the private room of the residents. Others had it in their restaurant. So it really depended on what the nursing home looked like. And what we saw is quite early in the study that the impact of these visits on the well-being was very high. And we saw in the beginning that everyone was very positive about the visits. So residents were very happy, family members were, and also staff members were glad that the residents were able to see their family again. We talked to a manager who said, these visits have a very positive influence, drinking a cup of coffee together, being together in the same space without a screen in between. It seems a small step, but it feels a giant emotional step. And somebody else said, a staff member cannot replace a family member. Since our residents know that they are allowed to receive a visitor again, they are in a different mood and have something to look forward again. And I think that really demonstrates what it meant for residents, but also for family members to have these possibilities to see each other again. And based on our pilot study, the Dutch ministry decided on the 15th of June to make the national guidelines less restrictive. For example, they said that more than one designated visitor is allowed. On July the 1st, they even concluded that nursing homes could open as usual. And I think what we learned from our study in the very first beginning is that the measures were too restrictive for too long periods. So we are talking about 2 months. We saw a directly positive impact on residents by allowing visitors back. Staff members, but also family members and residents themselves reported cases from practice of death by loneliness, and also deterioration of residents during the lockdown period. And what we also saw in the beginning was that nursing homes really lagged behind with regard to personal protective equipment. So in the first beginning, only the hospitals received it and nursing homes had to wait for a long time. And we really saw a debate coming up about infection prevention and quality of life. Our pilot findings were published in the Journal of the American Medical Directors Association. And recently we also won the Morley Award because our study and the Dutch guideline is seen really as a very good example worldwide to allow safe visits. In October of 2020, we conducted a new survey study in which we had a look at how is it going, was daily life back to normal, and did organizations feel prepared for a second wave? In this survey study, 63 out of the 76 nursing homes responded, and approximately 25% of them had COVID-19 infections at that moment, either for residents or for staff members. And most of the home indicated that they had to continue with their normal activities. That meant that residents, for example, could participate in activities again. They were allowed to go outside, they could leave their unit, they could visit family members at home, and they received all medical care and therapists. And it also meant that there still were some safety regulations in place. For example, we saw that a lot of group activities didn't happen. 3 out of 4 homes also indicated that the volunteers have entered the nursing home again. 1 out of 4 didn't. So one reason was that often the volunteers are older people themselves, and they belong to the risk group, so they were just afraid of getting infected. And more than half of the homes said that now we are in a situation where visitation looks like as before COVID-19. I would like to show you an example of one nursing home to make clear which steps they chose to allow visitors back. One nursing home we followed chose to allow visitors to go outside for a walk on May 27. in June, they said, okay, instead of 1, there are 2 designated visitors allowed and they can come in the afternoon. On June 18th, they said, okay, residents are allowed to visit family members at home or outside the nursing home, and our restaurants opened for residents again. At the end of June, they said 4 designated visitors are allowed and they can come with 2 at a time. And at the beginning of July, all visitors were welcome again without an appointment. And like said, the summer months, there were very little infections, so it was possible to be less restrictive in summer. And half of July, they opened the restaurant for the community. When we look back at October, the majority of nursing homes indicated that they felt prepared for the second coronavirus wave. In October, they had sufficient personal protective equipment, and what was sometimes a problem is that the test capacity was not okay. So people had to wait long before they could get tested. That also meant that when a staff member had to be tested, it could take a while before the staff member could go back to work because he could not get tested earlier. What we also saw is that the perceived stress of staff was very high. This had to do with high absence rate due to quarantine or long COVID, but also we saw a lot of tiredness from staff. It had to do with the constantly changing rules and also with conflicts with family members. So in October, we heard, or we saw in our data, that a lot of staff members have conflicts with family members who do not see the necessity of these personal protective equipments any longer, who do not want to follow the rules that the nursing homes has implemented. So if we have to come up with a conclusion, it was a very fragile balance between the fear of infection and also the impact of restrictions on the well-being of residents. And I think until today, there is still a very fragile balance. And the question comes up what the future will bring. To conclude, we saw in our study that a general ban for visitors is not necessary, and that it may do more harm than good for older people who live in nursing homes. We were very happy that in Dutch law, there is a regulation included now that says there is no more general ban for visitors. It can happen that a local ban is applied. So if there is a big outbreak within a nursing home, that's really up to the nursing home to deal with the situation, in the sense that they are allowed to choose to close the nursing home for a while. But what we prefer more, and what we luckily enough see more, is that they close, for example, a specific ward or unit. We see some differences between organizations when it comes to that rule. So some are very quickly in closing the whole home, and others say, okay, even in the case of infections, the non-infected residents can just see their relatives and these kind of things. What we really missed in the whole approach and all the year is that residents really should have a voice and should be heard. So a lot of decisions, or nearly all decisions, were made without taking residents' voice into account. And also family members did not have a say in that. So it was really the government and the nursing home organizations who can come up with regulations and implement all kind of restrictive measures without hearing the resident voice.
Thank you. Thank you, Ramona. Is there, people will have a lot of questions. So,
okay.
Yeah.
30 seconds. So what we also saw is that dignity at the end of life was very important. And luckily enough, after the lockdown, family members were allowed to visit the dying residents. And what I would like to give back to you, or to discuss with you also, is the impact of the vaccination. So we are now preparing a new study about the impact of vaccinations. What does it mean for the normal life of residents? And in the Netherlands, they are now talking about using rapid COVID tests to make more restrictions possible. And I was really, wondering how the Irish situation looks like and what are your opinions about that. Thank you very much.
Thank you so much, Ramona. And I'm really sorry, I have a horrible job here today because there's so much depth. And there's somebody who's a participant saying hello to you, a woman called Marita, wants to say hello to you. So I'm passing that greeting on. There are some questions. We've got 5 minutes. We'll probably get through a third of them, I would say. So what I'm going to do is to call out 3 questions and put them to the panelists, and then we will respond to the remainder that we haven't been able to discuss online. So thank you, Dr. Maeve, Majella, and Dr. Ramona for rejoining us. So the first question is from Cecilia. And then there's a question from Annette, and then there's a question from Ger. So Cecilia, she says, really interesting, lots of work for the future. With regards to now, what exactly is the law pertaining to restrictions? And maybe you talked to that. And to what extent can nursing homes, particularly private ones, use their own discretion in respect of this? So that's one question. So panelists note that. A follow-up question then from Annette. Should nursing homes or NEFIT have sought guidance from the courts with regard to the lawfulness of restricting residents' right to exit and have family visits? And then a question from Ger, which I think has come up from other people as well. Are the nursing homes in the Netherlands private or state-run or both? And to what extent does that happen? So I'll put those 3 questions to you now, and I'll call on Maeve to start, then Majella, and then Ramona. And we've got 5 minutes before we move on to the next session.
Okay. Okay, so the question of what can be done now, let's say there's a private nursing home that's not actually complying with the HSE guidance, which I presume is kind of the general gist of the question. And so what I'm saying is that I think that constitutional and ECHR rights are at stake here, and they're not just kind of nice to have policy considerations, they're actual law. Now the problem with, the actual law is that if there's a private nursing home, well, the state is the regulator, and under both Article 8 and Article 3 of the ECHR, which correspond then to the right to privacy and the right to bodily integrity and freedom from degrading treatment in the Constitution, the state has legal obligations not to allow people to suffer that unlawful, if it's a blanket restriction, or if it's at the end of life, for example, and it's really causing quite clear extreme suffering. The state has an obligation not to allow that and to intervene, but it would require, seeking legal advice as one option. Of course, raising the fact that it's illegal, wrong, and that it needs to be remedied immediately. And I do think it needs to be remedied by emergency legislation to a certain extent that people are all calling for. So I suppose adding the human rights law analysis to try and get some more urgency. I think there are recommendations from the expert panel that should be more about law than just policy. Of course, you need policy change, but also law. So that's what I'd say.
Okay, thanks, Maeve. So, and we do need to go to law, and we do need to go to the courts, is your short answer to that.
Well, it's an option. People shouldn't be deterred from seeking legal advice, I think, yeah.
Okay, thank you. Majella, any comments?
I totally agree with what Maeve has said there. I do think we need to change the way we even think of wording, and that visitation is not compassion, and even in our present guidance, it's referred to compassionate visits. And the law does need to change. And I don't have a law background, but absolutely.
Yeah, that guidance isn't enough and policy isn't enough, and even the words aren't enough. It's not compassion, it's about rights. Ramona, any comments to make on those questions?
Yeah, let me just answer question 3 about the public or private nursing homes. Most of the nursing homes in the Netherlands are non-profit, and they can be public, non-profit organizations, and we also see some, but much less private nursing homes.
Okay, and and thank you. So the model is not for profit in the Netherlands. What difference does that make, Maeve, in law, or does it?
Well, I really think the state is at risk by virtue of the fact that it is really failing to have legal accountability over these situations of extreme vulnerability, and which it is funding itself. So the state needs to sort it out, and of course, there should be statutory rights to home care, there should be statutory rights to advocacy in all care settings, there should be statutory safeguarding, there should be deprivation of liberty safeguards. Yeah. We are unfortunately, I think, quite, I don't know if we're unique, but we are extremely bad at protecting rights in social care settings, as we know from our history.
So the state isn't exercising its positive obligations, and there's huge gaps.
Absolutely.
Okay. Now there's a question here about the regulator. So again, if anyone wants to respond to this. It's from Carmel McGough. One is about nursing homes and the other is about the regulator. Do you ever think that it is sometimes suits private nursing homes that we cannot visit? Well done, Care Champions. Where is HICWA in all of this? Are HICWA still doing inspections? If so, I hope they are done unannounced. No inspection should be done by announcement first. So question about kind of motivations, and we can speculate, but I guess we can't be sure. And I think, Ramona, you have some interesting sort of evidence from your experience about the motivations of providers, but also kind of the role of the regulator. And again, if any of you might comment, and then we'll probably need to go back to the panelists for time. So Ramona, motivations of providers.
I wouldn't say that profit-driven companies benefit from not having visitors. We also had this discussion from some family members, but there is no reason to believe that, I think. And with regard to the inspectorate, it is also in the case in the Netherlands that the inspectorate didn't visit the homes for a long time. So that's comparable, I think.
Okay, Magella, you look like you've something to say here.
No, I just feel like, it's certainly something we often hear from families where they would feel that, it may suit nursing homes better not to have visitors, but you don't know what the reality of any situation is. And of course, unfortunately, HICWA doesn't have the powers that it really needs to be able to govern in the area that they are meant to. And certainly, I suppose, in cases where there's a massive outbreak and nursing homes are under pressure, it may possibly well suit them not to have the extra pressure or burden of families at that time.
Okay, and Maeve, any comment on the motivations of providers and the role of the regulator?
I think HICWA's role is very interesting. It's noticeable that they were saying to the Special Oireachtas Committee, well, we may have been at a lot of those early meetings when nursing homes didn't come up. The minister is wrong to say that we're the voice of people in nursing homes. We have far more things to be doing in addition to our job in relation to nursing homes. So, there's a massive need for a focus on nursing homes and the people in them. I think there's a real need for an Oireachtas Committee now on nursing homes, if not on human rights as a whole.
There's a
emergency powers. Like, there's emergency legislation coming out every day of the week, and I don't understand why some of the issues that clearly need to be patched up immediately can't be done through emergency legislation, such as the ability of HICWA to do individual investigations into individual complaints.
Yes, and I note that yesterday HICWA were in front of the Health Committee and they're asking for additional powers. And I've been banging a drum for a long time about adult safeguarding legislation, which would give social workers, safeguarding workers, the right to entry to investigate individual concerns. So there is a need for more law. The committee, there is a model in Westminster, I think that's probably worth looking at. So thank you, everybody. Thank you for your questions. Sorry we couldn't get to all of them. And I think, the whole, it's interesting, my mother-in-law was living in a nursing home in a rural part of Ireland, which was owned by the local GP. And that was a private model, but it was a very community model as well. So it was an interesting, but that has now been bought by a company that is headquartered in Beijing. And I think it's quite interesting. If you look at the Sunday Business Post, the consolidation that's happening and the remoteness of the ownership. And therefore that's an even bigger reason and case for a good law locally for the state to exercise its obligations, whether it's profit, not for profit, public, whether the headquarters is in rural Ireland or in Beijing. The person living there has to have their rights vindicated. So thank you so much. We're now going to move on to Dr. Sarah Donnelly, who is a powerhouse and a gadfly and an advocate in all matters relating to older people and their rights. She's an assistant professor of social work in the School of Social Policy and Social Work and Social Justice, and a member of the Irish Association of Social Work. And by the way, for any additional information, check out their website, www.iasw.ie. Prior to this, Sarah worked on the front line as a medical social worker for 15 years in Tala Hospital, and her research interests include aging and dementia, adult safeguarding, as she and I have battled in the trenches on that one, and capacity and decision making. And she is currently co-convener of the European Network for Gerontological Social Work. So before we hand over to Sarah, I just want to thank profusely Majella Beatty for setting the scene so clearly and cogently, for Maeve pointing us to the law, and for Ramona to show us what can be done if there is a will around opening up nursing homes for the benefit of people who are living there and the people who care deeply about them, their families. So over to you, Sarah, and you have 10 minutes. Thank you.
Okay, very ambitious 10 minutes. Thanks for the lovely introduction, Colette. And again, I'd just like to echo your thanks to our first three speakers and to all our speakers for giving so freely of their time this morning. So look, I'm not going to be saying anything in my talk that hasn't probably been said in some capacity before, but I suppose I'm looking really at the issue of autonomy for nursing home residents and the need to balance that with, I suppose, protection and human rights within the context of COVID-19 and visitation and beyond. So firstly, I suppose just when, and again, you know, we've touched on this in terms of the demographic of nursing homes. I suppose COVID-19 has very much shed a light on and exacerbated pre-existing weaknesses and problems in our health and social care systems. In most European countries, nursing homes tend to be regarded as a place of last resort and often are situated, I suppose, geographically and metaphorically off the public radar. Most nursing home residents we know are aged 85 years or over, have complex comorbid conditions, and often need a lot of help with activities of daily living. And again, we know that dementia is estimated to affect 4/5 of residents. Over the last 20 years, however, we've seen nursing homes increasingly been provided by private for-profit companies, and care often being paid for by the individual older person, as opposed to being publicly provided or publicly funded. In terms of the Irish context, we have approximately 32,000 people living in nursing homes. We have 576 registered nursing homes, of which 440 are private or voluntary nursing homes. And private entities manage 8 out of 10 or 80% of our beds nationally. So sorry, this slide's a little bit busy. And again, this very much reflects a lot of what Majella and Ramona in particular were referring to. So we know that when somebody enters, an older person, a person with a disability goes into nursing home or care home, their families still play a vital role in terms of providing practical, emotional and psychological support, and very much act as care partners. So I suppose the impact of cocooning and lack of visitation has had significant impacts. Firstly, that intersecting impact of self-isolation, often staff shortages due to COVID infections or sickness, curtailed visiting from family and friends, the constant pressure of death and fear about becoming ill has seriously damaged the mental health of nursing home residents. Again, Comas Herrera et al. Carried out a rapid realist review of the impact of visitor exclusion and found that residents were experiencing much higher levels of depression, anxiety, isolation and loneliness. And again, we also know that the bans have negatively impacted on mood and behaviour, particularly of people with dementia, resulting in increased use of psychotropic medication. Again, for family members, there's been impacts in terms of guilt, fear, worry and isolation, and Majella has spoken to that so well earlier. Again, we know there are particular issues around people with dementia, with many becoming withdrawn and depressed. They can't understand why their loved ones are no longer visiting. They can feel abandoned and are also losing cognitive and motor skills, including fundamental skills such as the ability to speak, eat or drink. And again, the Alzheimer's Society in UK talked about many families describing their relative with dementia as disappearing before their eyes. For residents with dementia and other residents, the absence of a loved one's regular visits to a care home or nursing home may mean a life not worth living for them. And again, our nursing home residents, our families have been so patient, but their patience is running out, and there is an urgency around reinstating visits and monitoring and compliance within that. I think there are particular considerations within the Irish context. And again, our Irish social work practitioners have highlighted the loss of residents' sense of connection to their families, but also their local communities. And this connectivity is particularly important within the Irish context. And I think it's important that we remember that. So again, I think when we think of abuse and abuse of nursing home residents, we often think about that as at the individual level, whereas often actually this can happen at the systemic or the institutional level. And certainly some of the most damaging consequences of the pandemic have fallen disproportionately on those in nursing homes in terms of excess deaths and mortality. Again, as Maeve alluded to, infringement of human rights aren't always intentional and can result from significant systemic weaknesses such as inadequacy in service delivery, failure to balance different types of risk, lack of accessible information about where to access services, supports or resource constraints. Louise Aronson, who's a geriatrician in America, has been reflecting on the situation of care home residents there and talked about the issue of elder abuse being when a trusted other, whether that's your country, the people in charge of the place where you live, your healthcare system, specifically neglect your needs or fail to act in ways that cause you harm or distress. And I think certainly the last year we could argue that has happened. However, we also know that health and social care services for older people have enormous potential to protect and promote their human rights. But currently we have a critical lack of powers for the investigation of neglect or abuse in private nursing homes, which I'm now going to talk about quickly. So firstly, as Colette alluded to, she's been very much a champion in terms of looking at the whole issue of adult safeguarding and the safety, protection and human rights of older people, and would have commissioned myself and my good colleague, Dr. Marita O'Brien, to do some work around this in 2019. And again, these findings are what we knew was happening on the ground, but again, gave us some anecdotal evidence, or not anecdotal evidence, evidence to what was happening. So firstly, safeguarding and protection teams do not have a legal right of entry to carry out investigations in private nursing homes. So while we have incredibly skilled social work practitioners who will try to negotiate, who will try and gain entry, that is not always possible. Again, as people have already alluded to, HICWA cannot investigate individual complaints, and they've been quite upfront about that. However, underpinning all of this, residents in private nursing homes should be afforded the same protections and human rights as those in HSE funded or HSE run facilities. So we can see one medical social worker reflecting when we wrote to HICWA, and they said, you know, we can't investigate. We can investigate the nursing home or we can do a visit, but we can't investigate a particular case. Again, the HSE has been quite explicit in, I suppose, acknowledging the shortcomings of the ability of safeguarding and protection teams, and I suppose used the phrase that where social workers are operating in the legal lacuna with no primary legislative basis for the work. So again, this is hugely concerning. Parallel to this, again, HICWA have been very explicit around their frustrations and the difficulties they have around governance and oversight of private nursing homes in particular. And Mary Dunyan, who is the Chief Inspector of Social Services for HICWA, reflected when talking within the context of the closure of Oakland's nursing home in Kerry, I suppose, about some of the difficulties around the legal limitations of what they can do, the amount of time that it can take to actually deregister a nursing home where there are serious concerns about the standards of care, abuse or neglect. And I suppose Mary made that very strong statement that people should not be subjected to significantly deteriorating care and service quality to the point that their very lives are at risk because of legal limitations. So people's lives are at risk, and I really, again, feel there is an urgency around addressing this legal gap. So again, some of challenges and solutions to keeping residents safe. And I suppose at the moment, what we have is we have our HSE 2014 National Safeguarding Policy. Colette has tabled, and we have an Adult Safeguarding 2016 2017 bill that's kind of stalled at the moment, but we also have a parallel process where the Department of Health are doing, I suppose, groundwork around the development of a national policy, but we're not quite there yet. But I think there's been some kind of interesting findings coming out of that. And I suppose part of the difficulty we have at the moment is we have such a weak or non-existent evidence base as to what's actually going on. So for example, we don't have real live data as to in relation to institutional abuse statistics at the moment. And again, I would really encourage the National Safeguarding Office to make that available. So what we do have is the Department of Health focus groups, which they commissioned the Institute of Public Health to do, so Sheehan and Sullivan. So firstly, I suppose Safeguarding Ireland have the Red C poll identified that almost a quarter of people, or 23%, would not know who to report adult abuse to if they or somebody else was being abused. Again, the Department of Health work has shown very low awareness of HSE safeguarding service, the safeguarding protection teams as a place to report harm, and this is coming from service users themselves. Again, service users reflected that it's difficult to report abuse by paid carers because of fear of repercussions, fear of being labelled difficult, and practical difficulties in actually identifying who to report concerns to. So if we think about a nursing home resident perhaps who has a hearing difficulty, communication difficulty, a dementia, how do they actually communicate that they are being abused or that there's a difficulty? Again, the Department of Health focus groups come up with some really good solutions in terms of service users would like to see routine mechanisms such as residents committees, service users committees, and suggestion boxes in nursing homes so that they can identify concerns and potential issues other than making a formal complaint. Again, the service user talked about the need for external or independent reporting and an investigating mechanism, someone to ensure that complaints are taken seriously to identify patterns of abuse, and some suggested that HICWA should take on that role. So again, I suppose coming back to the issue of mandatory reporting. So I suppose this is really around the obligation of either citizens or health and social care professionals to report abuse when they are aware that it is happening. Now, we do actually have mandatory reporting in respect of all citizens of Ireland under the 2012 Withholding Information on Offences Against Children and Vulnerable Persons Act, where all citizens are obliged to and mandated to report any information pertaining to murder, assault, sexual assault, kidnap or trafficking. So I suppose those higher Schedule 1 and Schedule 2 offences. But again, we don't have any mandate to report other types of abuse such as emotional, psychological, financial. So again, residents, regardless of their disability or level of cognitive impairment, should have a right to good quality and safe services and should be supported to make complaints and speak out if their rights are being impinged. The difficulty with the permissive reporting regime is that the decision to report can be subjective, dependent on professional ideology or training, and ambiguities are created because there's no statutory reporting requirement. What the advantages of mandatory reporting, and again, the literature would say, I suppose mandatory reporting must be treated with caution in terms of those overly interventionist, interventions, but what it can do is enable a targeting of early intervention measures or the flagging of high numbers of reportable incidents or multiple referrals. And I suppose there's a notion of certainty to this approach, and there can no longer be situations where individuals or institutions or organisations can turn a blind eye to abuse. And again, this can help act as a deterrent to abusers, given the intention of this type of legislation. And again, this is currently tabled within the Adult Safeguarding Bill 2017 as is. So for me, I suppose we really need to reflect and think about what changes are necessary. You know, crisis, I think, is interesting because it also means a time for change or opportunity. And for me, I suppose we really need to focus on the promotion of legal and civil rights and understanding that that's best underpinned by a human rights approach to prevent discrimination and abuse and to ensure social inclusion. And I think there's a real piece there around the integration of our nursing home and care home residents into our wider community. Again, you know, we've talked about this throughout all the presentations, family having that vital, caring, supportive, protective and irreplaceable role. And for this reason, visitation must absolutely be monitored and complied with visitation guidance. Again, I would argue that we urgently need emergency legislation, both in terms of enforcement of a monitoring of visitation, but also in terms of mandatory reporting, or at a minimum that either HICWA or Safeguarding and Protection social workers are given a legal right of entry to private nursing homes to carry out investigations where there are suspicions of abuse. And again, I think there is a huge urgency in that. We also really need the government to publish information on current trends and safeguarding reports from the nursing home sector, and to implement a strategic safeguarding response. And again, these are all things that the Irish Association of Social Worker have been very explicit in asking. I'm nearly done, Colette, 2 minutes. We also need to make sure that safeguarding is everybody's business. So we need awareness raising, not only the staff of nursing homes, but also the residents themselves, because in order to enact human rights, you need to know what those human rights are. You also need to know what abuse is. So really we need to empower people to challenge organisational norms and take action to safeguard themselves and others. Finally, I think as a society and as citizens, we need to foster intergenerational solidarity. We need to think about the types of society we want to live in. And overall, we need to move to that rights-based culture of human rights, access to service, quality of life, and safety and protection to all citizens, regardless of where they live.
Thank you so much, Dr. Sarah, for that whistle-stop tour, huge depth there. Turning our minds to the fact of institutional abuse, and it doesn't have to be intentional. And I think Aronson's definition is really, really helpful there. You very cogently set out the gaps that are there, the right to entry to nursing homes among adult safeguarding workers, the HICWA not having the ability to investigate individual complaints, and the lack of governance and oversight that the regulator identified, the weak evidence base, and of course the weak voice. I think that's possibly one of the most disturbing aspects of all of this. And the fact that, safeguarding is everybody's business, and the whole role of reporting. You'll be glad to know that the Adult Safeguarding Bill is back on the order paper, courtesy from my lovely colleague, Dr. Frances Black. I would urge all of you, make use of that. It's not the be-all and end-all of everything, but it's a really important vehicle on which you can tag and pin some of the things that have arisen today. So I'm now handing over to Dr. Greg, our Professor Greg Swanwick, consultant psychiatrist in the psychiatry of old age. He was made a professor in 1999. He currently works in Tala Hospital. I imagine he and Sarah were co-conspirators there when they worked there together, and you have a very special interest in services for nursing homes and dementia. And you've got 10 minutes. Then we have Sinead, who's got 10 minutes. And Sinead also tells me for everybody to tweet hashtag residents have rights and hashtag visits are vital. So over to you, Professor Greg.
Thank you very much, Colette, and thank you for the introduction. Thank you for inviting me to speak this morning. I'm not going to use any slides. That I suppose has the advantage too that I can be a little bit more flexible, and I know what everybody else has said, so I'm going to try and not repeat things and try and come up with maybe some new points. As Claire said, I'm an old age psychiatrist. I've been visiting nursing homes for the past 20 years. So my job is actually to visit people in nursing homes. I don't have a clinic. I see people where they live. And I've also been interacting with family members over that 20 years as well. And one of the points that I'd like to make is that over the 20 years, I've observed a lot of improvement, and particularly in managing the psychological and behavioral symptoms of dementia, which is the piece, I suppose, that I spend most of my time doing. We also see people in nursing homes who do not have dementia. We see people with disorders like depression and so on. But the bulk of the referrals to our service are people with behavioral or psychological symptoms that are associated with dementia. And I have seen a very substantial improvement in care of those people over the years, moving from a model where a lot of medication was used to a model where there is a lot more use of non-pharmacological interventions. And a lot of those non-pharmacological interventions are based on communication skills, and they're based on interactions with family and about family life, which is what we are here about today. And one of the things that I feel is unfortunate is that I think that one of the impacts of COVID has been to in some way reverse some of those improvements that I've been seeing over the years. And I just wanted to make a few points about that. And I want to relate to actual people that I have been seeing over the last couple of months. Also bear in mind that there have been changes with each phase of the COVID pandemic as well, and the problems have changed a little bit from phase to phase. And thinking about, well, where do we go from here for the future? One of the areas that hasn't come up very much yet, I think, in any of the talks, is about that entry point to nursing homes. And a couple of things, particularly in relation to that I have come across, is that pre-COVID, patients themselves or their families would have had an opportunity to view nursing homes before they went there. And very often at the moment, that is not the case. Particularly maybe if somebody is going from a hospital, if they hadn't been planning for some time to go to a nursing home, they may be in a position of having to go to a nursing home without having viewed it in advance. And I think that is a huge disadvantage and impact. It impairs their ability to make choice about where they go. Now, some nursing homes that I visit have had innovative ideas about this, and they have been able to put virtual tours online for people to look at in advance. But it's not quite the same as going to the nursing home and maybe meeting the director of nursing and meeting staff and so on, and being able to talk to people. So that's one huge impact, I think, that COVID has had, that entry point to nursing home. But just as importantly, and I think possibly more importantly, is that first phase of settling into a nursing home. And what is really important, and one of the things that I and my service have advocated for over the years, is that the nursing home and the staff that are going to be interacting with that person over the coming months and years need to really know that person's life story, and they need to know their family. And that is really impaired at the moment because they're not getting to meet the family, and they are certainly getting bits of information that are sent in or emailed in or things over the phone or by video calls and so on, but it's not quite the same as meeting. And the bulk of the referrals that I get relate to people with dementia. So people who have difficulty remembering parts of their life story and will have more ability to remember more distant things. And one of the things that we always advocate for is that there are personal memorabilia in the person's room, and that the nursing home will have access to photographs of family members and so on, so that they can keep the person engaged with conversations about their family. One of the difficulties in that, in somebody who's got memory impairment, is that if you keep asking them questions, you know, who is your brother, or who are your sisters, or what did your father work at? If they're not able to remember the answers to those, that can be distressing for that nursing home resident, because they're in a position where somebody keeps asking them questions they don't know the answer to. So what is key is that the staff members in nursing homes have all the personal information and the life story that goes along with the photographs and the photograph albums and so on that might be in the room, to help the person keep engaged with their family. So rather than saying, who is this in this photograph? Isn't that a lovely photograph of you with your sister Mary when you were visiting somebody else or at a wedding or whatever it is? So the nursing staff know what the background of the photograph is. That was something that we saw was steadily improving up to the onset of the COVID pandemic. But there's been a setback on it. And I think that setback has been in part due to there's a lot of staff changeover, particularly after the first phase. People were concentrating on other things. They were concentrating on physical health, and they had less access to families, and families had less access to nursing homes. So I think that is something that I would really like to see, that we would regain ground. A couple of the other non-pharmacological things that I think have been really important. I think of a lady in a particular nursing home who her big enjoyment was to go out with a family member and to go for cake and coffee in a local restaurant that was out away from the nursing home. Again, that has stopped. There's no amount of other things that are going to maybe replace that, and it's about getting back to those things as quickly as possible. Other things like that had been put in place, so pet therapy, where dogs and other animals were being brought in for nursing home residents who enjoyed playing with dogs to be able to interact with. A lot of those things were done by outside providers, and again, they have had to stop because of restrictions. And the more and more of these things that can actually be done and involve families in those interactions with residents, the better. Another thing that I've directly observed that hasn't really been mentioned, I think, very much is the impact of masks. I have visited a number of residents recently who were really quite upset and distressed by masks. And again, it's about this local policies as to whether which staff members in nursing homes are wearing masks, whether all outsiders coming in, whether all relatives coming in have to wear masks. But just to bear in mind that it can be very distressing for some residents. And another point on visiting is, again, I think it's very important that no one size fits all. So I think it was Magella mentioned earlier about visitor pods. And I know some nursing homes in our area have gone to a lot of trouble and have built perspex areas where visitors can come. But again, to think about that and be aware that, again, one size does not fit all. I remember a conversation with one relative in particular who was very distressed by the perspex pod because what it really brought up for that family member was what you see in maybe films or movies about visiting people in prison. And very often, I think the whole impact of COVID, where people are more, if you like, imprisoned in nursing homes and are not free to leave, and now you put in this kind of visiting pod, which makes it feel and look even more like visiting somebody in a prison. And it's to be aware that while these things may be very well-meaning, that they can have very adverse effects. Just continuing on that theme of the impact on carers, and again, the impact on the carers of not being able to visit and on the carers' family life. So a gentleman that we have seen recently, whose wife is in a nursing home. He himself had been ill in hospital. He has a chronic medical condition, and he himself has suffered from depression. And he was the person that we were actually seeing for depression. And one of the things that happened during the relaxation of the restrictions and when he might have been able to visit, unfortunately, this man was in hospital. And it was just soon prior to him going into hospital that his wife had been admitted to a nursing home. He had heard about other people, friends of his, who had visited other people and their family members in nursing homes, and found that their relative had no longer recognized them. So his greatest fear and what was impacting on his psychological state was when he did eventually get out of hospital himself, and when the restrictions were eventually lifted, would his wife still recognize him when he did get to go and visit her? And fortunately, there's a happy ending to the story. He was able to visit her there just before Christmas, and she did recognize him. And that had a massive impact. We think about the impact on her, but also the impact on him and his psychological symptoms. Another story, which is the same kind of situation, is a lady who had just gone into a nursing home. She had been living at home with a family member. And again, it was happening that this lady, at the stage of dementia she was recognizing people less and less. And certainly when her family member were trying to do video calls or telephone calls to her, she did not recognize them on the phone or on a video call. And one of the recommendations that we had made was that there was possibility of doing visiting on compassionate grounds. So absolutely, I think a compassionate ground is to allow visiting so that the resident in the nursing home will still have that level of contact, that they will recognize their family member when they call to see them. I think that the final point that I want to make about this is around training and around training of nursing home staff. So we have talked a bit about the regulation and the statutory basis for some of the regulations around nursing homes. I feel that there should be mandatory training for all nursing home staff so that they fully understand what dementia is, how best to care for people with dementia, then the whole spectrum of non-pharmacological interventions that might be used. The real fundamental importance of involving family and knowing the person's life story. So there's two parts to family involvement. There's the part of allowing family to visit and facilitating family to visit and for the resident to go out with family, but also that the staff member who is dealing with that resident today knows that person's life story. so that they can reminisce with them and they can use the reminiscence materials, the photographs and so on that are in the room. And I feel that we need to do more in terms of training nursing home staff on these skills, because it's not something that necessarily comes naturally, and people need to be trained to be able to use these.
Thank you.
I'll finish at that point.
Thank you so much, Professor. And it's a painful role that I have. Thank you very much, Professor Greg Swanwick. It's a very difficult role I have today, stopping, because each of the presentations we could spend so much time on. I think really important encouragement that in your experience professionally, that you saw an improvement up to COVID. So we know that things can be better and we can go back to that. And the small things that make a big difference, like you know, the rooms and the personalization and people's things, but above all, to know the person, to know their life. You know, a person has had a lived life, and how important that is in terms of respect, but also in terms of the connection for today. And I would wholeheartedly endorse your recommendation around dementia awareness training. I was for a while CEO of the Alzheimer's Society of Ireland, and I could absolutely champion that, that people would have access to that kind of training. And again, small things can make a big difference, but sometimes those small things which can seem obvious don't actually happen. So really encouraging stories. So I'm now going to ask Sinead McGarry to do her presentation. Again, a fearless and a dogged campaigner and advocate in this area. Sinead, I've gotten to know quite well in our work together with the Irish Association of Social Workers. She's a co-author of the Irish Association of Social Work Liaison role in nursing homes and residential care. So a bit of an expert here in this space. Sinead has worked in a variety of medical settings as a social work team leader, and most recently acted as research assistant to the Irish Association of Social Workers COVID-19 and Social Work Survey. I'm really asking you to try to stick to the 10 minutes so that we have a chance to at least answer one or two more questions, and also to encourage people to tweet. Thank you. Over to you, Sinead, 10 minutes.
Great. Give me an L cough, Colette, because we know my tendency not to be brief. So thanks to everybody. And I'm just going to slice off a few slides and get straight in, because I really want to, I suppose, amplify some of the work that the Irish Association of Social Workers have been doing. And it really is, I suppose, a passion project, because all of this work has been generated from volunteer social workers. And I think that speaks to the connection that we have with the nursing home sector and the people who live within it and the families around them. You know, just a very quick piece to say around our own advocacy voice. We don't just sit on the sidelines observing the lived experience of the people we work with. We're actually proactive as part of our regulation as registered professionals to speak up with and for those who are at risk or aren't heard. And we look for the change that is needed to tackle that inequality that we experience on the ground, and the resources to make that happen. And I suppose that means that we're interested in the lived experience of social policies. In terms of our own perspective on the central role of family life, a lot of this has been covered. I just want to highlight, I suppose, the role of residents and the voice of residents. You know, we need to start asking residents and families to provide solutions. And that's why it was really important to us that when the residents were asked to give a perspective to this webinar today, that we actually asked them what are their messages to government. And we asked care champions to come along. It's to ask what are their asks for government. Too often we see in the media or on the news that the resident or the family member appears and provides the story of the suffering or the harm or the stress that they've experienced. And we need to really place them at the centre as the experts with lived experience and look for the solutions that they feel would change their lives for the better. I think the other key part in relation to residents is that residents are equal citizens with the same right to safe access to full family life. And you know, my own parents are in their late 70s and early 80s and have been cocooning for much of the last year. And when lockdown restrictions ease, they see their family on the basis of their rights to familial life, not on the basis of subjective compassion. And social workers have been really concerned about the increasing, I suppose, medicalisation of family life, in the sense of we've introduced 7 measures to allow service providers or people providing care to judge how much somebody needs to see their family. And we have been very vocal on this from the start, that visiting guidance should be based on rights to family life. Equal rights across society should apply. And I think that's a really, really key point that needs to be heard at political level. The other points I think have been well made there, that by other speakers, we need to, I suppose, change the system and stop leaving rights to family life to the discretion of individual service providers. And I'm very conscious, by the way, that we may have nursing home providers listening in today. We're not talking about the cultures in nursing homes that have supported family life and that have gone above and beyond to maintain connection. We've heard some fantastic stories of that. We're talking about cultures which have been defensive, which refuse to put visiting guidance in writing when they introduce excessive restrictions to those outlined in visiting restrictions. So I want to give that shout out to anybody who's listening in as a carer or as a nursing home provider. We know that there's really good standards of care. This is a different experience. So I suppose, sorry now, oh, have I frozen a bit? What have been the barriers to progress in terms of the perspective that we bring? There's been delayed investment and a hands-off approach. So visiting pods, and I totally take Greg's point there in terms of, visiting pods may not be for everybody, but certainly the quality and the range of visiting pods that have been provided in the country range considerably. If anybody takes a look at some of the pods that Ramona is talking about, they're beautiful, homely environments. They have plants, they have, a very personal kind of approach that would make it feel like a welcoming room with communication facilities, two-way communication to facilitate hearing. So people aren't shouting through screens. So quality is really important. We only invested in them in December of this year, of last year. And we haven't enforced or monitored either our visiting guidance or access to visiting pods. We don't provide any guidance to families when unreasonable visiting refusal is encountered. So if a nursing home introduces excessive restrictions, the government has simply and repeatedly said families must go back and negotiate that with the service provider. What is of particular concern to social workers is that government messaging is identical to that provided by the service providers. So when politicians or representatives of governments are asked about concerns that professional social workers are raising, that human rights experts are raising, that advocacy groups are raising, and that most importantly, residents and families are raising, the response is that provided by service providers, which is that we're overrun, which is that we have been in crisis, and that is taken as the narrative for all nursing homes. So there hasn't been that acceptance or that acknowledgement of the fact that there has been unreasonable visiting refusal in services that could provide visiting. And it's interesting just to point out, even when we talk about that overrun narrative, we have talked about the chronic staffing level, and of course that has happened, but other jurisdictions have used Army and Civil Defence Forces to support visiting. In the last wave, 4 private nursing homes looked for the freely available Army assistance. So I think we really need to challenge and forensically analyse some of the approaches that have been taken and ask why other solutions weren't put in place. Solutions to manage communication during outbreaks were overlooked, and I'll talk a little bit about that later. I think the elephant in the room relates to the lack of governance. We don't have governance over 80% of the nursing homes in our country, and that really makes it difficult for the government to go in and enforce change. What have we told government? And I suppose the big message from social work is that at no point can ignorance be claimed. We have been crystal clear over the last year. We were writing about the model of visiting that was proposed and later rolled out in terms of Ramona's research from last year. We've asked the government to look at international visiting evidence. We have asked for a rights-based guidance, and that a resource would be provided for those cases of unreasonable visiting refusal. And just to point out, in the absence of any action or response from government, we actually provided that resource in a voluntary capacity to care champions. We also think that that information should be freely available to people. You shouldn't have to ring an advocacy service or a social worker to know your rights. That should be freely and easily accessible to families so that families and residents can speak up for themselves. We want to amplify and empower people to act and seek support as they need it. But what is going to really strengthen residents is that the people in their immediate circle are aware of their rights. The other piece, I won't go through every single thing there that's on that slide because some of it has been mentioned. Just under the protection slide there, though, we have been very clearly, as Sarah pointed out, looking for the introduction of emergency measures for mandatory reporting and the legal right of entry for social work. Again, that is in context of the removal of the vital protective eyes of family. We have basically created a system. Successive governments have introduced policies which have developed a primarily business model and a privatized model of social care. We have then failed to regulate or put in adequate safeguards. That's acknowledged by HICWA, by the National Safeguarding Office, by social workers and by others. And within that context, we have now removed the vital protective eyes of family, which are just the eyes and ears for social workers and for the state in the context of the system that we've created. So that's why we're saying there is no time to delay. We have been very clear with government around this, that the longer they delay, the more the risk of harm will be experienced. And just to say, I think Sarah echoed this earlier, we have had a very clear line from domestic violence servicing, that domestic violence services, that cocooning increases risks of harm of violence. We also know that TUSLA have said the same in relation to child protection, and that's internationally accepted. We don't talk about the risks of institutional abuse increasing, despite all we know in this country about, I suppose, leaving people behind closed doors in care settings. And that's in any care setting, because culture can change and harm can be experienced in any setting. So we haven't actually monitored. We have asked what are the current safeguarding trends, how many cases of abuse and neglect have been reported over the last year. That information is not being tracked or monitored at the moment. And if it's not being tracked, collected or monitored, it means that we're not responding.
Sinead, it's now 25 past, and I do want
I'm gone. My last line is simply, I'm going to leave it at this. We have proposed a number of models, and one of them was a liaison model to connect people. We put in a psychologist into every nursing home in the country, private and public. We asked that families and residents had access to the same so that they could have a sense of connection. Those two quotes there give a very clear guidance in terms of the value of that. When there's a liaison social worker in place, connecting people, helping them feel that they have support, even if they're on the other side of a wall, to feel connected when somebody's at end of life, versus people standing outside windows. We can do better and we should do better. And that's it.
Thank you so much, Sinead. And again,
sorry
to be asking people to be shorter than we'd ideally like. And I think that the takeaways is that, you know, the Irish Association of Social Workers have, you know, nobody can say they didn't know. I think that's hugely important point. And the second piece is that there's been really clear ideas put forward, including the liaison worker, the liaison social worker, and the difference and the importance that has. So we've time for some questions. I'm going to read out 3, and I would ask you to be brief. And thank you for Dr. Sarah and Professor Greg, and to yourself, Sinead, for all you've done this morning and all you do. And you know, as Maya Angelou always says, when we know better, we can do better. And I think we should be able to say that at the end of this session. We've covered a lot of ground. So Ken Irvin has a question here. It's a practical question. What extent does family fora or family committees exist or are active in Irish nursing homes? In a personal circumstances, there seems to be no way to connect with other families. So that's a really interesting point as well. The suggestion to the nursing home management seemed like a novel idea to me, to them. So that's one question. I think Lena asked a question. Basically, my dad's nursing home is insisting on a screen visit as well as masks. And Professor Ken talked a lot about masks. Also, visits are supervised, so there's questions around privacy, no touch allowed, and my dad has dementia, and touch is really important. Is there anything we can do about that? Then I suppose a lot of questions about the implications for the acute hospitals as well as nursing homes. And I guess it's when can we begin to get back to a new and better normal, you know, to summarize some of the questions. So, and we'll respond to all. So I'll start with Sinead. Any thoughts on those questions?
I'd just say very quickly in relation to the voice of families, we should have family councils in nursing homes feeding up. We should have resident councils in nursing homes feeding up. We need to stop the professionalization of the voice of residents and families. We actually need to allow them as a community to share their wisdom, knowledge, and experiences.
Is there information on that at the moment, to where they exist? And
yeah,
where
they're in the Netherlands, they're in Germany, there's another jurisdiction.
But in Ireland, have we got data?
With it, no. And again, this is about, you know, changing and learning and looking outward and challenging some of what is the status quo. But I think we also need to really challenge ourselves about the overuse of the expert narrative in the lives of people.
So that's really, really important, and we can learn lessons from abroad. So that's a good idea. Sarah, any thoughts or comments on those points raised?
No, I would really just very much echo what Sinead said. And again, I actually don't know if we have resident councils or family councils. We should have them. They are best practice. Again, that has come up in the Department of Health focus groups. I know those models, as Sinead said, are very well established. All US nursing homes, as far as I know, do have resident and family councils. And I think that's something we really need to move to. And as Sinead said, we really need that service user voice. Like the very fact that we couldn't get anybody who felt safe to speak out today, to me speaks volumes. So there's a lot of work to be done there. I'm going to hand over to Professor Swanick's expertise around the visitation and acute hospitals, because I can't really comment on that.
I'm not sure what exactly the question was about the acute hospitals. I mean, I think a lot of the same things apply. Exactly.
I think it's that, you know, people can be in there for a long time and you have the same sort of disconnect between people and their families. Yeah, so it's exactly the same issues really, and remember that some people are in hospitals for very long periods. That's right. I was looking after one lady in hospital there recently who had been in hospital for over a year, so before COVID started. So that's a long time to be isolated away from your family. Just on the idea of family councils, and I think family members meeting each other. Again, there were some good practices that were evolving prior to COVID. So some nursing homes that I go to were running family groups. And so that was evolving. And of course, that has been set back by COVID, because all of those kind of interactions have been set back. So thank you very much, everybody who's given their time today, for Magella setting us off, and indeed Cliona for having the words of Patrick, who is a 91-year-old person living in a nursing home, having his say this morning and orientating us to the people who matter most. To Magella, Beatty, and really kind of painting the picture of what's happened. What the situation and circumstances. Sometimes we're looking at historical abuse. This is real life happening around us, and it's great to have organizations like Care Champions, real live advocates, real live data emerging, but also the opportunity for us to do something about it. And Maeve pointed to the law very strongly, the use of the law, and to be proactive about that. And there's a number of opportunities that she's identified. We also heard from Dr. Ramona and her insights from studies of nursing homes and changes that have taken place to the good in the Netherlands, and where we can learn from them. We've heard from Dr. Sarah, who talked about the kind of the gaps that need to be closed in adult safeguarding law and reporting, and all of those, and the contributions that they can make. And Dr. Gregg, you reminded us that, you know, things can get better. I think, you know, there's somebody talked recently about the politics of hope. We, as well as kind of painting the picture and talking and being honest, and I think Sinead talked about that. Nobody can say they didn't know. That's really, really important. But also we need to hold out the possibility that things can and must get better for people, whether it's people who are living in nursing homes or people having access to the kinds of home care that might be better matched to their needs. So I want to thank everybody. I want to thank all of the speakers. I want to thank all of our fantastic participants who've more or less stayed with us, for the fantastic questions, for all the tweeting. And yeah, we're only, how many seconds after? 4 minutes behind time, which I consider a personal failure. But I think I might have been run out of town otherwise. There's a lot to do. We've got opportunities to do it. And by that solidarity that Sarah talked about, I believe we can. You know, what is it James Baldwin says? You know, nothing. I'll mangle it now. I know. Not everything that's faced can be changed, but nothing can be changed until it's faced. We've faced a lot of things today, and we've plenty of ideas. Thank you all. Thank you for the Irish Association for Social Work on your leadership, and indeed UCD. Thank you so much.
Thank you.
Thank you, everyone.
Thank you.
Bye-bye.
Bye.
Bye.